you very much to invite me to take part to this webinar today. I thank you, first of all, Ezisurg Medical, to have taken an idea and to organize this meeting. This meeting is focused today on laparoscopic bariatric surgery, and we have the honor to have 3 surgeons beside myself to take part to this meeting with lectures and videos. And the doctors comes from Europe and Middle East. The first one is Dr. Tarek Mahdi, from United Arab Emirates. And then there is Dr. Aider Maki from, again, United Arab Emirates, and Dr. Miralas Ilic from Serbia, if I pronounce well. So it's really a great pleasure to open this session, and I hope we can not only present our talk, but we can have a great scientific discussion with sharing experience, personal experience, and comparison to the literature and the techniques and results reported also, recently in literature. So I would like to remember to participate, to pose the questions at the end of each presentation, because at the end of each presentation we open the discussion, and maybe we can also switch with written sentences by chat. And the objective is to construct a scientific webinar and to have a home message from everybody. Again, we are grateful to Ezisurg Medical to have taken this opportunity and invest a lot of efforts, also from technical point of view, to organize these 2 hours together and to see the last development of the techniques, for example, the staplers that a surgeon can use already in the operating room, and also for the last models in the future in each OR. So thank you. And let's go to the first speaker, which is Dr. Tarek Mahdi. Dr. Tarek Mahdi is a professor at the Department of Endocrine and Metabolic Surgery in Sharjah University Hospital, United Arab Emirates. It is a great pleasure to have him for the time reserved this morning. And he's going to speak on bipartition is a new concept in metabolic surgery. Dr. Mahdi, the webinar is for you.
Thank you, Dr. Lebri, and thank you for Ezisurg Webinar to give me this opportunity to share you this very nice webinar. And yes, my project today is bipartition, is new concept of metabolic surgery. All of us know the metabolic surgery is nowadays established concept which originated from remission of diabetes and weight loss. And all metabolic surgery, we are going to disturb the anatomy of the gastrointestinal tract to get a benefit in one hand and to get some complication in other hand. And the ideal metabolic operation must be easy to do it, a less learning curve, resolution of the metabolic syndrome in the form of obesity and diabetes, hypertension, and also less complication, less nutrition deficiency. And the most important one is easy exit strategy. The right of your patient at any time ask you to convert it to the normal again. It is easy operation to select the easy operation to convert to the normal. We have a lot of surgery in bariatric market. And we have a Roux-en-Y gastric bypass, the golden operation, pancreatic diversion, mini gastric bypass is the new era nowadays. Sleep gastrectomy is the commonest bariatric. And all of this achieve good result in diabetic control and resolution of diabetes. But the problem is this current metabolic operation create another disease to treat metabolic syndrome. Some procedures place obstacle against the food, ingestion through the use of narrowing anastomosis, and sometimes use of prosthesis, and this will be dysphagia, vomiting, stasis, esophagitis, and also the malabsorption operation, exclusion operation, cause atrophy of the mucosa with bacterial translocation to support that system, especially worse the hepatic condition in a patient with frequently present with some degree of non-alcoholic fatty liver disease. The most part operation in the market is a malabsorptive one, leading to less protein and nutrient like calcium, iron, and folic acid. If you look for a gastric band, the first bariatric operation, we will see that it depends on internal restriction. There is in the first bite. But the problem, the complication is erosion and dilatation of the esophagus, and also cannot obstruct soft food with high calories. So it is not metabolic operation at all. And the mechanical restriction is not a physiological way to lose weight. In gastric bypass, the golden bariatric operation need also mechanical restriction of the form of really short pouch, very narrow gastrojejunal stoma, which are related to the weight regain after Roux-en-Y gastric bypass. Also, we have distant dilemma, how much you are going from the trans ligament, from the duodenojejunal. If you have the all the addition, 50 centimeter, there is a lot of failure. So we are going to increase the peripancreatic limit to 150 or 200 centimeter, and this also has good metabolic results, but the same worse nutritional results. The malabsorption operation, scuponaro surgery, which is the most powerful operation in the weight loss and in the remission of diabetes, and its modification to the research was developed in 1989. But excessive weight loss is around 80%, and resolution of diabetes type 2 up to 95% with scuponaro or duodenal switch operation. But the problem, more and more diarrhea, more and more frequency anemia, cirrhosis, routine undernutrition, and sick face. So this is the intestinal malabsorption. And also the same other form of diversion, mini gastric bypass or SADI, has the same dilemma of the length of peripancreatic limb. When you increase the length of peripancreatic limb, you will have a good metabolic response. And at the same time, we have a lot of nutritional deficiency. So diversion and exclusion create to induce malabsorption, not for correction of the metabolic disturbance. So we need new hypotheses. We need to delete from our bariatric dictionary the words of restrictions and malabsorption. Fortunately, we have a new pathway. Why you are going to divert if we can do bipartition to adapt the new form of the food and you have the same results. Adapt and the physiological basis of the pure metabolic surgery is nowadays a new concept in the metabolic surgery. We need just bipartition. We don't like to exclude the food from the duodenum and first length of the small intestine. If you look here, why all of these people will never fat? What changed? Mainly diet. The quality of diet and the amount. The biggest difference is refining. Nowadays, we have more pre-digestion. We become flour, can become pure sugar, and juice, no natural juice nowadays. And sometimes we have liquid become a maize. What is the problem with pre-digestion? The problem is digested food is not expected in duodenum because the simple sugar disappear in the first 70 centimeter of the duodenum. So human diet nowadays become unnatural, hyper calories, pure fiber pre-digested by cooking and refining, extremely easy to be absorbed in the more proximal portion of the bowel, creating a peak of nutrient absorption. And the distal bowel tends to have less absorptive and less secretion of GLP-1 BYY, which is responsible to control the satiety and control the insulin secretion. If we compare with the diet here, with the refined diet, with no cellulose and the primitive types, all our diet, we will discover that all the food is completely absorbed in the upper part of the small intestine. But in the primitive diet, we will see the diet go up to the lower intestine, which is stimulate GLP-1 BYY to secrete and control the obesity and control diabetes. So in obesity and metabolic syndrome, we have duodenal hyperactivity and ileal hypoactivity, proximal distal imbalance. So if we come back to physiology to know what will happen for our satiety and spinal satiety and gastric satiety, when we become hunger, this will increase the ghrelin hormone and decrease the GLP-1 BYY. And fast gastric empty, inducing spinal satiety because GLP-1 BYY increase and ghrelin hormone decrease. This leading to also slow gastric empty, but still eating because there is another satiety, the gastric satiety, which depends on gluten. And this gastric satiety is depend on the size of the stomach. But you must remember, the gastric satiety come after the intestinal satiety. So if we compare two opposite states of fasting to avoid hypoglycemia and provide increased glucagon, decrease insulin, endogenous production of the glucose and the fat acid into the blood, but after meal, to avoid hyperglycemia, the glucagon decreasing and insulin increasing, inhibits the endogenous production of glucose and the clearance of lipids. So you can imagine after 8-hour fasting, you eat this, what happened? Insulin secretion. Why hypoglycemia doesn't care? Because glucagon increase, which guard against hypoglycemia. So GIP was secreted from the upper intestinal tract, stimulate produce glucagon and the insulin. If you don't eat sugar, you must produce sugar. So if we look here, what is the difference between the upper and the lower intestinal hormone? The upper one in the form of GIP, reduction of glucagon and the insulin, and the lower one, reduction of insulin and blocking glucagon and stopping gluconeogenesis. So the neuroendocrine activity of proximal gut avoided hypoglycemia, secretion of insulin and glucagon and gluconeogenesis, production of insulin and glucose together to feed the hungry cell. Doesn't block gastric emptying at all and doesn't cause satiety and doesn't end meal. But if we are going to see what will happen in this target when we are going to secrete GLP-1 BYY, this efficient lowering glycemia and efficient blocking glucagon secretion, very efficient in stopping gastric emptying and strong satiety, and also in the meal. So this is a physiological response to food ingestion. We have GLP-1, which reduce gastric emptying, separation of pancreas to increase secretion, decrease glucagon, hypothalamic satiety, and decrease ghrelin hormone. But in a metabolic syndrome, we have block of all of this. So we find modern food nowadays leading to proximal hyperactivity and distal hyperactivity. And you know, nowadays we have a lot of big companies behind this refined modern food. We can't change our food nowadays, but we can make some adaptation of our gastrointestinal tract to adapt to this new food. So in metabolic syndrome, GIP hyperstimulation create insulin resistant and high stereotypic fat deposition. So if we are going to active immunization with against GIP with improved metabolic status in high fat feed, which is proved by Montgomery et al. Into 2010. And also, this is the origin of concept of energy barrier system, which decreasing the amount of the food which touching the duodenum, this will decrease the secretion of GIP. What's about the distal gut? Yes, the distal gut hormone tend to low or at least relative low. So if you receive analog of GLP-1 beta in the form of Victoza or Saxenda, this will improve the condition. So simple ileal glucose infusion leading to increase the insulin sensitivity also in osteoarthritis. So nutrient in the ileum make you feel and behave like being fed. So we discover the problem here. We have the problem in the ileum. So we have different way for positive action. You are going to block the proximal gut activity to complete exclusion, or to stimulate the distal activity in the ileum to secrete GLP-1 and PWY in the proper time. So if we look here, if we compare a herbivore and the carnivore gastrointestinal tract, you will discover in herbivore, which have food increasing fiber, we have very long gastrointestinal tract. But in carnivore, which is dependent mainly on the meat with less cellulose, you have short gastrointestinal tract. Even in the surgery, when we are going near from the ileocecal valve, we have a lot of metabolic response, but at the same time, we have a lot of nutrition deficiency because we are going to use it in the form of exclusion, and the exclusion means a lot of nutrition deficiency. So better metabolic result towards nutrition, so exclusion may not the best method for metabolic surgery. We need to delete mechanical restriction and the malabsorption. We need functional restriction. We need intrahormonal intervention. We need pure metabolic surgery. So we have two types of restrictions, the mechanical one and the functional one. The mechanical one as a band, range, narrow anastomosis, static and permanent, and obviously to the food passage and activate with the first bit. But we need functional restriction. This circumferential at the end of the meal and limit stocking. And sleeve gastrectomy causes functional restriction, no obstacle to the passage of the food if it is not tight to the sleeve. At the same time, faster gastric emptying in the beginning and limited stocking at the end. And also sleeve gastrectomy has neuroendocrine surgery because we remove the fundus which secrete ghrelin hormone, so decreasing ghrelin hormone will help for satiety also. So the sleeve gastrectomy because functional restriction and endocrine adjustment. So it is pure metabolic surgery. Also, how to obtain a more potency without any restriction or malabsorption? We are going to bring the ileum closer to the stomach to induce early release of GLP-1. We need the food to pass through the duodenum and the upper intestinal, and we need to push some undigested food to the ileum to stimulate the GLP-1 and PWY secretion at the same time during secretion of GIP. So we stimulate the upper and the lower, and this will help us to induce more powerful in the metabolic response and at the same time less nutritional deficiency. So the digestive adaptation theory started with Michel Gagné in 1999 with sleep gastrectomy, and with Sergio Santoro from Brazil with transit hypertension, and with me and my team in 2013 in a SESI bypass. The inventor of gastric hypertension digestive adaptation theory is Sergio Santoro from Brazil, starting with sleeve transit hypertension. He will make this anastomosis in Roux-en-Y fashion, but me and our team, we have some modification of this operation to make it so easily and derive it from concept of the mini gastric bypass to develop SESI bypass. SESI bypass is a good design model to adapt the gastric chamber with decrease to induce gastric satiety from the start, reduce the ghrelin hormone, create a major stimulus of food, so avoiding processes, we're avoiding malabsorption, we're avoiding mechanical restriction, we're avoiding excluded segment. Also, as a Scubinaro operation, here we stimulate the ileum direct, but bypass a lot of small intestine. But here in the SESI bypass, also we stimulate the ileum through this anastomosis, the ileum to the antrum. And at the same time, it is easy, safer diagnosis. And also, we don't have exclusive statement. Every millimeter of gastrointestinal tract will touch it by food. And also total endoscopic access. If you have something problem in the biliary system, you can go through endoscope through pylorus and go to the biliary system. And also the antrum and pylorus preserved. No nutritional big problems and no prosthesis, no mechanical restriction. And also it is very flexible procedures because we can use it in obesity and you can use it in type 2 diabetes with mild obesity because the smaller gastric remnant and the big remnant is related to the metabolic one. Also, if we compare it with the sleeve transient bipartition, it is easy to done, no mesenteric defect, and we have the same results. Also, it drains the sleeve, so reducing the high intragastric pressure, so we can use it to treat the leak after sleeve gastrectomy. Also, it keeps the stomach in right position, no coiling at all with SASI bypass. If you see, sorry. If you see this picture after your operation, sorry. If you see this picture after your operation in the first day, you will see the gastrografine pass to the ileum and also to the pylorus. In the two ways. This means this is good operation. This is a endoscopy after 6 months. You will see here the two opening. This is one opening, and this is the other one. This is the opening of gastrointestinal anastomosis, and this is pylorus. Also, it's so easy exit strategy. If your patient at any time asks you, please, I don't like this operation. Please, I'm not happy with this operation. Please, it is enough. It's okay. I have a good weight now, and I need to convert to the normal again. In 10 minutes, you can convert your patient to the normal again. You just put your stapler in the anastomosis and cut it. It is so easy. And the right of your patient at any time to ask you, please convert me to normal again. So metabolic operation nowadays, sleeve gastrectomy is not enough for metabolic operation. And duodenal switches carbonaro is too complicated operation. But SASI bypass have the same result with no exclusion, no malabsorption, and the good metabolic flow. So the main conclusion about bariatric, we promote ileal stimulation and partial proximal deactivation. We add to sleeve gastrectomy power to become more and more metabolic operation. Also, in revision, after a sleeve gastrectomy, it is so easy to improve the power of the sleeve gastrectomy in weight regain after surgery to add to the ileal, gastroileal anastomosis. This will good option after a failure of sleeve gastrectomy for patient with just obesity. This some results about, this is 2 years follow-up of SASI bypass. It is around 85%. And also this is improves the metabolic problems, especially type 2 diabetes. SASI have a good as Scabonaro and duodenal switch around 95%. And this is the biochemical profile, pre and post-operative. We didn't find any problem with it. Also, this is the nutritional value. And also nowadays, SASI bypass went global all over the world nowadays, in Latin America, in Africa, in Europe nowadays, and in Asia also. So standardization of the bariatric, especially SASI bypass, done for all bariatric operation in India in 2019. This is the standard of primary SASI bypass. If you like to do SASI bypass, you must follow this measure, because if you didn't follow this measure, you will expose your patient to a lot of complications. So please, if you like to do it as this. First, the distance of sleeve transsection from esophageal gastric is 1 to 2 centimeters, 3 centimeters wide is the sleeves. and 6 centimeters the distance from bronchus to do your gastroileal anastomosis, and the width of gastroileal anastomosis must be less than 3 centimeters, and the length for the gastroileal lip from the ileocecal valve is 3 meters, and the volume of the sleeve around 150 to 175. So the evolution nowadays from classic bariatric surgery to bariatric metabolic surgery, and now for pure metabolic surgery without significant restriction or malabsorption. Thank you for your attention, and I'm ready for all of your questions. Thank you.
So thank you, Professor Tarek Mahdi, for the excellent presentation. It's a really a good pleasure to have met you this morning and listened to your talk. First of all, I ask to the person connected to this webinar if there are some questions. No questions. Okay, so I have a question. Of course.
Okay, please.
So, Professor Tarek, listen, when did you start to do bipartition, laparoscopic bipartition? After you have met Dr. Santoro, or you started before?
Yeah. I met Dr. Santoro in 2011. He presented his operation and helped me, and starting to do it sleeve transfer bipartition in 2011 for 1 year. Then I discovered it's so difficult to operation, and the learning curve, we have a lot of esoteric defects. We must close it. So I am the ex-fan for mini gastric bypass, and I told Dr. Santoro why we are not going to have the same concept of mini gastric bypass to do this operation. He told me mini gastric bypass is not popular in Brazil, and almost always we have Roux-en-Y gastric bypass. So all of our work depends on Roux-en-Y, not single anastomosis. I told him I have a good experience with mini gastric bypass, and we didn't find the bile in the stomach is normal. Bile in the esophagus is dangerous, I know. So it is doesn't matter. I will start it, and he really helped me to start single anastomosis, and I didn't find any the same as many gastric bypass, but the difference is no exclusion at all with least nutritional deficiency, and this operation is the most powerful operation as the Scobonaro operation in remission of diabetes. I have many patients have diabetes more than 10 years, and the result is excellent with them. So I'm starting in 2012 to do this operation with help for Dr. Santoro, and Dr. Santoro invited him many times to my hospital, and he's happy. He told me I will try to start it because it is so simple. No, any surgeon have any experience with bariatric surgeon, he can do it easy, and also at the same time he can convert your patient to normal easy also. And this is a good option after sleeve. We have a lot of sleeve now with regain after sleeve gastrectomy. You know, sleeve gastrectomy is time factor operation. It takes 3 to 4 years that the patient will come back again for weight regain. This is a good option and the easy option for the patient for weight regain after sleeve gastrectomy, especially with reflux esophagitis. My friend Michael Kramer in Munich used SASI bypass to treat the reflux after SASI bypass after to treat the reflux after sleeve gastrectomy with SASI bypass. It's a good series, more than 100 cases with reflux after sleeve, and treat them with SASI bypass.
Yes, and thank you for the reply. My comment is, now in your practice, you do all the time or most of the time the bipartition, or you do other procedure? I mean, you start with sleeve gastrectomy and then you propose bipartition for revision, or you start immediately with bipartition?
No, usually I am Roux-en-Y gastric bypass surgeon. Then after sleeve hysterectomy, we shift for sleeves and we shift for mini gastric bypass for bariatric. I will tell you something. But we don't have the golden operation for obesity and metabolic syndrome. So you must have a lot of tools in your hand to treat your patient. This is your weapon to treat obesity. Usually nowadays, if the patient is just pure obesity without any other metabolic abnormality as diabetes, hypertension, hyperlipidemia, and he didn't have any reflux, I start to sleeve gastrectomy for him. If have the patient after a sleeve gastrectomy have reflux, almost always I shift to Roux-en-Y gastric bypass. But my friend Michael Kramer started to do cystine. I will never do cystine bypass and reflux after sleeve. I don't have experience, but my friend Michael Kramer in Munich have a good experience in this. For me, if reflux after sleep, shift direct to Roux-en-Y gastric bypass because this is a good operation for reflux for me. If the patient is diabetic and obese, from the start, I'm shifting to SASI bypass. If the patient don't like, this is the right of your patient. I can't select for my patient. I just offer him the advantage and disadvantage for the operation. And if your patient asks you, no, I'm sorry, I need mini gastric bypass. Okay. If you need Roux-en-Y gastric bypass, it's okay. You must have all the tools in your hands. You treat obesity. It is a chronic disease as a cancer. It is multifactorial disease. We don't have golden operation. Nobody can tell you I have the golden operation of my hand. I treat all of the time with obesity and diabetes. But we add something to the market with this complication. We need all people to start to do it. I give you another tool in your hand. I don't push you. You must do it. No, nobody can push you to do anything. And also, there is another advantage of this operation. In poor country, and I'm sorry, because the company will never be happy with this one. In poor country, you can't buy the stapler because it's expensive. You can do SASI bypass just with suturing. You can do plication of the stomach, and you can do manual gastroiliac anastomosis. It's a cheaper operation. You can use it. My friend Almantis from Estonia, he started to do it. We have thesis about the non-stable SASI bypass. This is another tool in your hand. I add something in the market can help our patient. I'm not here to tell you I have the golden operation in my hand. I told you there is another way. It's a bipartition. Please thinking. We need to decrease. We are here to improve the quality of our patient, not to do operation alone. I must select the proper operation to my patient. Sometimes the patient is not educated. How you are going to do for him mini gastric bypass? Mini gastric bypass need, I'm the ex-fan of mini gastric bypass. I have a lot of mini gastric bypass, but he needs good educated patient. You need high protein diet after surgery. Without high protein diet, you lost your patient. I lost a lot of my patient after mini gastric bypass because it is not educated. Mini gastric bypass have good results, but you need well-educated patient. You need patient know you are going to do operation to resolution of diabetes and weight loss, but you, on the other hand, you must have a lot of protein and a lot of vitamins. And sometimes they can control. So we are here to improve the quality of life for our patient. So we must have a lot, and you can offer your patients the best one.
Okay, so it's clear. Yeah, I agree with your point of view. Also, if I disagree about the possibility in terms of cost to, for example, propose a gastric plication plus bipartition, for the simple reason that unfortunately the gastric plication, we know that the results are not good. And moreover, there is also the problem that when you go back and you revise, you can have some technical complication after gastric plication. Anyway, I think that I like very much what you said about first point is that in your hospital you have an algorithm. So you propose to each patient the best procedure you think for this patient, and not the same procedures or the same two or most popular 2-3 procedures. So you have a various armamentarium to consider in favor for example, comorbidities like diabetes or sleep apnea or hypertension, of course, and also about the previous bariatric surgery, because you mentioned that you can see also patients coming with a previous bypass or a previous sleeve with a weight regain or persistent comorbidities, and you have to treat them because you just said a true sentence, which is a disease, obesity, which kills. Is not an aesthetic problem or only a mental problem. So I agree with what you said. And I also agree about your algorithm. I don't have personally, and also in our center, experience with bipartition. What we do when we propose a malabsorptive procedure, we are simply historical because we propose a duodenal switch. And we do also quite often a duodenal switch in our hospital, and also, especially, for example, for super obese patients, which can reduce the BMI with the first procedure, like a sleeve, and then we add a second step of duodenal switch in order to try to get the objective to reach a BMI which is not anymore in obese class like previously. Of course, I suppose we didn't speak today, but I suppose in your center you have a multidisciplinary team working with you, because obesity, as we know, is not only a technical or surgical aspect. The patient must be, first of all, addressed by different specialists in a multidisciplinary team in order to offer to the patient, like you mentioned, the good operation that surgeons need to know and to propose, and not only one or two procedures. My question is, before to start in 2011, like you said, the bipartition, did you do some other malabsorptive procedure, or you just started and you continue with this one?
No, I told you, I'm the surgeon was Roux-en-Y gastric bypass for many years. Then after sleeve, we starting with sleeve. Then after that, we shift to mini gastric bypass, and there is some SEDI bypass also. We use it, but we never do scapularis operation before. I need a small comment about the plication. Plication is based on its technique. If you look for CT hang in Thailand, in Taiwan, he had a good result because he has his own technique in plication, and he published a lot of articles about his technique for plication, and have a good result. For me, plication and manual SESI, it is one option. Your patient, sometimes you have very poor patient and obese patient diabetic. What can you do for him if you don't have campaign for maybe you can help him for 2 or 3 years to solve the problem. I am with you. I revise a lot of medication, and I'm suffering when I go to inside to revise medication from failure to convert it to Roux-en-Y gastric bypass. It is so difficult operation, especially as vertical banded gastroplasty. We have in the past, we have a lot of vertical banded gastroplasty, and when you convert it to Roux-en-Y gastric bypass, we are suffering. The problems, you can't guarantee any procedure for patient and tell him this would solve all of your problems. Almost always, I tell my patient, I'm just helping you. I just help you in 50%. Still, there is 50% on you. You must share me the decision and share me the effort. I'm trying to help you, but still you have something, because you know the problem of weight regain is not only failure of operation. It is patient factor. It's very important. So it is, as you mentioned, it is the chronic disease. You must treat this chronic disease as a cancer. You have many options in your hand. You have surgery, and you have dietitian, you have exercise. So you have a lot of tools in your hand. Not only single decision you can give here for your patient. So deal with obesity as a cancer. You need MDT for obesity to select the proper one from the start, and tell your patient you will go for many stages of treatment. One of them is surgery.
Sorry?
You must tell your patient, treat the obesity as a cancer. You need MDT to select the proper plan of care of your patient, and the surgery is the one option. Still, there is diet control. Still, you have exercise to get good results for your patient. If your patient is not ready for diet control and exercise after operation, it's so easy to tell my patient, I'm sorry, I can't do anything for you, because surgery is one arm of the story. But still we have two arms. You must use it.
Mm-hmm. Okay, perfect. Okay, so if there are no questions, Dr. Illich, do you have a questions? Yes?
Yes, I would like to say to Professor Badi that I also agree with his concept. I do a few bipartition in patients after sleep, after rebate, and I have success with that operation, and my patients are happy with this operation. Of course, a period of following is still short. So I would like to ask you, Professor Mahdi, what is the longest period you follow your patient with bipartition?
This is a very nice question, because we are preparing for publishing the 5 years survival. I have a patient with complete follow-up now for 7 years, because the follow-up of the patient is so difficult. But I have 5 years. I will start to publish it in obesity surgery this year. We have also multi-center follow-up. I'm collected from all centers from Turkey, from Norway, from Germany, from Egypt, and from United Arab of Emirates, and from India now, and from Iran. Iran nowadays has the biggest number. Iran exceeds 1,500 cases of SASI bypass. There is some problems in Iran about the measuring. I contacted my friend and I told him, please be sticky for the measurement of the length from the ileocecal valve is 3 meters, and the gastroileal anastomosis must be less than 3 centimeters. We are facing same problem also in Egypt, because in Egypt we have a lot of bariatric surgeons in Egypt, and the expert one. But the problem, everyone have own length. Some doctor make the limb, 1.5 meters from ileocecal valve, one make it 2, one make it 2.5, and nobody can stick. And I told all of my friends, please don't dominate this operation as SASI, because SASI is 3 meters from ileocecal valve, it's 6 centimeters from pylorus. You can do your anastomosis, and the anastomosis must be not exceed 3 centimeters. If you make your anastomosis more than 3 centimeters, you convert the operation of diversion operation. And if you must do your anastomosis with anterior wall in the antrum, because some surgeons do the anastomosis with the body of the stomach. If you do your anastomosis with the body of your stomach, you will convert it to complete conversion, because all the food are going to the ileum. You must do your anastomosis with 6 centimeters from the ileocecal, from the pylorus in the antrum, anterior wall, because if you are going to do the anastomosis with the posterior wall, become more dependent, your anastomosis must be less than 3 centimeters, because if you do it more than 3 centimeters, you will convert your operation to complete diversion. And your patient, you will have a lot of nutrition deficiency. We need the food to pass through the pylorus and through the anastomosis, gastroileal anastomosis. We need small amount of undigested food to touch the mucosa of the ileum, to stimulate the ileal cell to secrete BWI and intestinal hormone. This is our target, not to divert all of the food to the ileum, because the ileum is the secret of the story of the metabolic syndrome.
Okay, so if we agree, we move forward, because we need to follow the program, and overall we have to start the next lecture. So thank you, Professor Mahdi, again, and we continue. So now it's my turn, and I present a video case with a conversion of sleeve gastrectomy to gastric bypass with a reduction of hiatal hernia. I didn't introduce myself, but I work in Belgium, and I'm currently moving back to Italy, the country where I come from, after roughly 20 years. And so it's my pleasure to give this talk, and overall, because this is a procedure that we can consider joining the discussion with Professor Mahdi about the revisional surgery when the patient comes back with a problem after the primary surgery. And we know that the GERD, so the gastroesophageal reflux, esophagitis, and also the Barrett's esophagus are significant after the procedure of standalone sleeve gastrectomy. Sometimes, and this is very important to remember, we have the symptoms which are not so referred by the patient, also because the patient maybe doesn't come especially to the consultation following the multidisciplinary team, as we've spoken before. And so the patient can arrive later with an esophagitis grade D, or unfortunately sometimes with a gastroesophageal cancer due to a reflux after roughly more than 10 years of sleeve gastrectomy. So this is the reason why the problem of GERD must be diagnosed before the procedure of sleeve, and also during the follow-up. A strict follow-up has to be undertaken in order to understand if the GERD or the esophagitis, or anyway some reflux symptoms appears and becomes important in terms of not only presence but also pathology that can develop. And so we see, for example, this very recent meta-analysis reported on hours of surgery in 10,000 patients, 46 study. And we see that after sleeve gastrectomy, it's important, there is an increase of GERD of 19%. And patient with no reflux before sleeve present the sleeve as de novo in 23%. So these two data must reflect the bariatric surgeon before to perform a bariatric procedure. And as Dr. Mahdi remember, the surgeon need to know different procedure and offer to the patient the best procedure considering the different comorbidities and also the potential complication that the procedure can bring the patient during the follow-up. And so we see also that the prevalence of esophagitis in a long term, which is after 5-10 years, we have close to 30% and also 8% the prevalence of Barrett esophagus. Barrett esophagus, esophagitis are all diseases that can bring the patient with years, with time, into an oncologic route, and this is really a terrific result. So the clinical case of today is a 54-year woman with lap sleeve gastrectomy in the previous 10 years, with an associated sleep apnea as usual, the obese patient when it comes to the consultation for the first time. And so we see that the BMI originally is not very high, it's in the class of number 3 with 44. She had good results and she lost weight until 26, and then she started to regain weight. But the problem was not only to the weight regain, because we are still in class number 2 of obesity with 38. The problem is that the patient presented a sliding hiatal hernia, gastroesophageal reflux, and grade B esophagitis. And so in order to avoid a continued increase of this complication, try to resolve the problem of the sleeve. So this is the video. We started and we finished with a 3-trocar technique, which is a reduced laparoscopy. And you see here the classic adhesions between the previous sleeve and the here. This is a trick in order to do not insert other trocars, but to expose the gastric region. We use a percutaneous straight needle, and we expose and we retract the left liver lobe with a percutaneous suture taken by Kelly graspers. And here we see the previous sleeve a little bit dilated as usual, but we see that the hiatal hernia is present, okay? So we have a quite large hiatus with an adhesion with the proximal sleeve. So we start with adhesiolysis between the upper part of the stomach. We recognize here the left crust, and we skeletonize the left crust, and then we pass on the right side and we skeletonize the right crura. We use as the school the coagulative hook. We see the surgeon habitude. And after you have freed the right crura, we the classic passage or a cotton tape like the surgeon used to do for a fundoplication. We use this because we have to reduce the hiatal hernia. And in order to reduce the hiatal hernia, we use a needle holder 10 millimeter, like a gold finger, to do the dissection sharply, and then we use again the coagulating hook to dissect the adhesion. Here we reach the base of the left crura in order to prepare it for the further cruroplasty. And here you see, quite classical, the pre-hernial lipoma, that it is one of the reasons of the persistent reflux in a patient with hiatal hernia. And here we remove the lipoma and we start with the cruroplasty. There are different schools. We use here the Silk 2.0, and we use a figure of 8 suture. And again, you see that we use intracorporeal suture with, you will see, intracorporeal knot. The surgeon, like we remember before, has to be able to do not only perform different procedures, but also need to be skilled as well in order to do intracorporeal suture and intracorporeal knot in the same time. Here we do other suture in order to close the hiatus, and we use again a non-absorbable suture like a Silk 2.0, and we use again intracorporeal knot. In order to try to reduce the risk of recurrence, we do also a lateral, anterolateral suture in order to close better. And of course, we check later the passage of an orogastric bougie. Here, we identify what we call the esophagogastric junction. We stay 5 centimeters down, and we open perigastric, what is the previous lesser sac, in order to have the introduction of the stapler. The stapler, Ezisurg Ezi-Endo, is introduced on the left side of the patient, and it is calibrated into the previous sleeve gastrectomy. Since it is a revisional surgery, we use thick cartridges like a green cartridge, and we section the gastric sleeve, and we do 2 stomach in order to have a gastric pouch upper and the rest of the sleeve down. You see here, we take time in order to place the stapler correctly, because don't forget, this is a revision. So sometimes the tissue can be double, and in order to avoid a misfiring and to have a good positioning of the graft, like in this case, we have to place the stapler correctly. We need, most of the time in this revision, 2 loads. You see here, again, we use a thick load, and the thick load is good enough because you see that there is not too much bleeding on the stapler. And so this is important when you have not too much bleeding and also not misfiring of the stapler. It's important to remember that the color on the thickness of the stapler you use is correct. As per habitude, we place some suture between the two stapler line. And why? Because we use also in other techniques between the stapler line just to reinforce to avoid potential complication. And it takes a few minutes and it's done. Bon, after this step, we do here a reinforcement of the gastroesophageal junction because we did a dissection, we did perforate, we didn't any perforation, but since it is a revisional surgery and we can have a difficulty of this tissue in terms of fragility, we can overzone and avoid potential leak. Here, we start what we call the gastrojejunal anastomosis, completely done by hands-on technique, like Professor Mahdi remember during a bipartition with the gastrojejunal anastomosis. And here we select a bowel lobe going up to the stomach without tension. So we do not measure like most part of the surgeon does, but we just do a selection of the lobe without any tension. And then we do a gastrojejunal hand to side, completely hands-on technique with a PDS1 suture doing the posterior anastomosis, like you see here. After you have finished the posterior wall of the anastomosis, we use a second suture and we push down the orogastric bougie close to the opening of the gastric pouch. As per habitude, we open the pouch by coagulating hook. You can use other devices like ultrasons or radio frequencies, and we open also the small bowel. Then we do the second suture outside the opening of the viscera, and this is an important step. And after that, we continue with the closure of the anterior wall with a continuum running suture PDS1. In order to avoid the leak, we use the running suture to close the angle, the corner in the medial positioning. And here you see that for posterior running suture is used to overzone the corner medially and to avoid the leak, because usually the leak are at the corner of the anastomosis. Of course, before to finish the stomach, we overzone and we close the anterior running suture with the wall ends here, and we do an intracorporeal knot using both suture on the anterior side. After that, we continue with the measurement of the alimentary limb, but before we transect the biliopancreatic with, again, an Ezisurg stapler, but white load, so not so thick like the green, and the vascular if you want one. And you see here there is no bleeding, and on the stapler line, we open immediately the biliopancreatic, and then we start with the measure of the alimentary. We measure 50 centimeter. We use 2 Kelly grasper with a pro forma number in order to measure quite fastly. And here we open the end of the alimentary. We introduce the stapler again, white load, and we introduce the stapler into the alimentary end of the alimentary limb and the proximal biliopancreatic, in order to do a side-to-side linear mechanical technique. Then we close the enterotomy with running sutures like the PDS-20. And here you see we close with PDS-20. We use preformer knot in order to gain time to do this suture, and then we arrive at the end where there is the staple line, and we do an intercorporeal knot, and the procedure continues and finishes with the closure of the defect. This is very importantly, we close the mesenteric defect in order to avoid an internal hernia, and we use a non-absorbable suture like polypropylene 2.0, and then we do at the end the extracorporeal knot, and in this way we finish the mesocolic step, and then we go to the closure of the Peterson hernia. The Peterson hernia needs to be closed in order to avoid again an internal hernia, and is the defect between the mesentery of the alimentary limb and the Peterson space, the transverse mesocolon, and so it is closed by a running suture with a polypropylene 2.0. The procedure ends with a leak test by liquid and hair and the placement of the drain. The results you see here are the discharge of the patient after 30 days with good results at 1 year, especially for care. And when we do here, this is very interesting, the comparison between the previous barium volume. We see here the sliding hiatal hernia here of roughly 3-5 centimeter, and here we see the sleeve, okay, the previous sleeve with the antrum and with the duodenum, and here the conversion, you see the drain in place because it's done on the first postoperative day, and here you see the gastric pouch, the hiatal hernia reduced, and the jejunum. So when we look in literature, we have a recent paper with 89 patients, and we see here that there is, first of all, a successful technique by laparoscopy, and also a successful results in terms of care. And conclusion are that technically we can consider this procedure to treat the hernia, the reflux, and also the residues of obesity. But we don't have to forget that the problem of the care is a problem that can afflict the patient after sleep. So I thank you, and since I have to moderate, I ask to the surgeon online to propose me questions if there are questions. Yes, Dr. Ilic.
Congratulations, Dr. Dabri. It was a wonderful operation, but I would like to point that antrum was a very, very large in this case, and I will talk later about that, about proper antrectomy in gastric sleeve. So, but operation was beautiful. There is no any full duplication, just only suture of crura, and it is good result.
I don't know if it is a good result because unfortunately, Professor Ilic, the problem is that the patient has still a short follow-up. And so we know that unfortunately this problem can be resolved quite immediately after surgery, but can also came back after a few years. So first, we have still a short follow-up. But about the antrum, you will surely speak about it later. And the reason why we didn't do any, for example, raised leaf gastrectomy, which can be considered, especially as I told during the presentation of the video, that the stomach was dilated, which is quite, quite common after a revision of sleeve, is because, as you have seen in the pre-op Barney's volume and also perioperatively, we had hiatal hernia to treat. And so this is the reason why we prefer to do not submit the patient again to other surgery in the future and to don't choose the hiatal hernia reduction and the raised leaf gastrectomy at the same time, and we choose this conversion. But of course, it's an option which can be discussed with the patient. I see online, and I welcome Professor Haider Ahmadi. Thank you for joining us.
Good morning, thank you. If I may, can I ask one question? Or it's
yes.
A little bit, yeah. Have you used the ICG, especially in original cases?
Yeah, ICG, very nice in questions. I use ICG in a revisional bariatric surgery, and this procedure can be used, of course. The principle is to have, if we can, an advert about a potential leak due to less vascularization. And I didn't use in this case, but it's an option to use, especially in revisional surgery, in order to identify the good vascularization in the good pouch, for example, during a revisional surgery going to a Roux-en-Y gastric bypass, or if we do a raised leaf gastrectomy and we want to be sure about the good vascularization at the angle of his, or when we do like, for example, dissection of the duodenum, to do a duodenal switch, or to do other procedure as like a SADI. And so, yeah, it is a good element to be considered. And in our practice, we used to consider the perfusion by indocyanine green with a revisional surgery, not only in bariatric, but also in general.
Usually, at what time you give the injection? Night before or early morning?
Sorry?
At what time you give the injection usually for the ICG? You give it that night before surgery or early morning?
No, do you mean when I do injection?
Yes. Yeah, you have to give the ICG injection.
Perioperatively. Perioperatively? Yeah, sure, because when we do liver surgery, this is the only case we do roughly in the case of metastasis 1 week before. But usually for the other cases, also gallbladder, we do perioperatively, because perioperatively you have the effect of the vessels green or the common bile duct green, and the vessels disappear from the green after roughly 8-10 minutes. So if you don't use perioperatively, you cannot profit about this option. Okay?
Thank you.
No, thank you to you. Now we move forward, and now it's your time, Dr. Maki. And let me to introduce yourself. You are a senior specialist of bariatric, but also general surgery in Al Qasimi Hospital in United Arab Emirates. Yes. And you're going to speak on postoperative emergency department visits are a quality indicator for any bariatric surgical problem.
Okay.
Please.
So, can you see my screen? Can you see my screen or not? it okay, or can you see my slides?
Yeah, sure.
Oh, okay. So thank you very much for the very nice invitations. I have to mention that I work under Dr. Mehdi for the last 6-7 years, and I'm really honored to see him again. Good morning, Dr. Tarek. Dr. Tarek was our head of department, so we collectively collected our patients for over 3 years, trying to analyze why the patients coming back to the ER, what's the main causes, and we tried also to find out the readmission rate, or whether we need some intervention or any factors that help us reduce that. And at the same time, we put a time interval before and after having a center of excellence. Does it impact the rate of ER visits? So let's see. We used our electronic medical report compiled with our ministry bariatric registry database, and we obtained the ethical approval for this data information on collection. A short glimpse about our hospitals, the biggest hospital in Sharjah with a 336 bed. Bariatric surgery started by Dr. Mehdi al-Wahidi in late 2008. The first center of excellence, the SRC, obtained in 2019, with later the CCP JCI Advanced Bariatric Accreditation in 2020. I think most of you know that UAE is within the most 10 obese countries in the world, as no one to hide it. About our procedures, what we're doing in general, the sleeve is number one. Then it was the mini gastric or the OAGP, which start to fall down with the raise of the RONY bypass, and we maintain the SASI on the same rate. But the 2020 were hit by the COVID as the rest of the populations. All of you know that emergency departments is a valuable resources for the patients across all specialties, but we never done any analysis before why our patients coming back to the ER. So that was a very good opportunity that we can use. We analyzed several variables, including patient demography, age, sex, BMI, the closest to the surgery, the length of stay, the interval between the discharge and the ER visit, the different types of complaints the patient came to the ER, and we try to see also different types of surgery and the effects of them. So, in our findings, we have 597 cases for surgery done between 2018 and 2020. A total of 204 patients came back to the ER for one reason or another. Majority were female, 67.2%. For the age, majority of the age as our patients between 20 and 40 years of age, with a BMI between 40 and 60. Sleeve is the highest number for both cases, and done on the ER visit. Coming back next to the mini bypass, then the SASI, then the RONY, and revision only have 4 cases that came back to the ER. And noticeably, in the robotic group, only 1 case came back to the ER. Just to mention that SASI have a different criteria or different instruction we give to the patient when to come back to the ER, because it's still under study. So it's a total different instruction that we give to the patient, and the rest with the other bariatric instructions. For the robotic, we noticed, as we said, only 1 case came back to the ER. Maybe it's related to the instrumental flexibility, which is highest at the robotic compared to the laparoscope, making the shearing movement at the minimum compared to the laparoscope. Besides, the robotic goes to a deeper area, in our area, easier than the laparoscopic, even making less shearing movement. And even noticing for our inpatient, this requirement for the robotic is less than the laparoscopic in general. We have 3 peaks, we divide it to a 3-time interval within the first 30 days, which is the highest peak, then between 3 months and 1 year, then the 30 days to 90 days, which is the lowest. Here's the chart showing the most common or the most common reasons why the patient visits the ER On the top of them is the non-specific abdominal pain, dizziness, and fainting attacks. Non-specific abdominal pain related to many causes, and the differential diagnosis of abdominal pain after bariatric is really diverse and present a diagnostic and a therapeutic challenge. And the presentation of the pain or description by the patient is highly variable, and the evaluation might be complicated by the fact that obese patients might feel the symptoms different than the need objects. In general, the most common causes of non-specific abdominal pains is on top is the maladaptive eating behavior, which is a common cause, especially in the area of postoperative, especially in the bypass cases where patients have an altered satiety and may not perceive the fullness into the pouch, dilate to the point of pain. Then we have the food impaction. Some patients may be prone to transient impaction and causes pain, most common within the first 6 months of the surgery. Such food intolerance are highly variable. We know that hydroglycic foods such as rice, pasta, bread, or fibrous foods such as meat, vegetables are common causes. We always advise the patient to take them in smaller quantity or to be avoided altogether. We have also the iron and the vitamin B12 deficiencies. All the factors still unknown causes abdominal pain, but still have to be measured by both before and after the surgeries and correction to be done. Then we have the bacterial overgrowth, especially in the excluded stomach or in the excluded bowel, should may cause pain or non-specific GI symptoms. Who can use the hydrogen breath test may be helpful to diagnose these cases. Then we have the functional GI motility disorder or causes non-specific abdominal pain. But we have to remember that obesity itself is independent risk factor for multiple motility disorder, like the IBS or esophageal motility. Then in one of the groups, we have the constipation, which is, I think, common in the early postoperative period. And it's usually localized to the lower abdomen. Then the biliary colic, which takes a good percentage of our patients, especially on the long run. Rapid weight loss may contribute to the increased bowel lithogenicity, and which is a widely acceptable risk factor for the cholelithiasis. Still, our patients suffer from dehydration and combined with the urinary tract infection. We always advise about the weight dehydration, dietitian advice, but still, we suffer from this, especially in our weather in UAE. It's quite charming with the heat, especially these times in summer. One of the other reasons that we found is the post-op chest infections, pneumonia, atelectasis, especially before discharge. Those patients were liable to come back to the ER, whether for obliterative chest pain or post-op fever. Then we do CT scan upon some sort of atelectasis or lower chest infection, which is treated by antibiotics. The other thing that we attract our attention is the back pain, especially after rapid weight loss. There are many theories after that, but the main three things is the bariatric surgery itself lead to weight loss in the stomach region, which means that the whole core area will need to work less hard to hold you up. So pain after rapid weight loss from the back muscle, because it's continued to be tense, like the entire body tries to adjust to the changing weight. The other theory is that pain in the lower back may also arise because we lose the supporting fat, which acts like a cushion in the lower back. And one of the other things is that the body may be struggling to adjust to the naturally changing center of gravity as we lose weight. It was mainly concentrated in the upper part, now it's shifted maybe to the lower part. So we can still be confused where is the center of gravity. When we saw there is a number of patients that registered and never showed, or some of the patients registered only for emotional support. Some patients reported that they visit the ER because they want an immediate evaluation of their symptoms. In most of the cases, they were simply just want to obtain reassurance. Still, post-bariatric patients have this sense of fear of leak, anything that happened to them, they think is the beginning of leak or some internal complication happens. For the interoperative variables, of course, we have the bypass cases. It's more complicated and may take more time compared to the sleeve gastrectomy, which may be more prone to nausea, vomiting, dehydration, which may increase the rate of ER visits. Then we try to analyze the length of stay. Does it related or not? We noticed that increased length of stay to discharge time may be associated with an increased risk of ER visits. We attribute this to the formidable occurrence of the postoperative complications. Some patients, like before discharge, they say, "No, doctor, I doesn't feel well. See the pulse, see the labs, it's all fine, but he doesn't well." Then, once we discharge him, a few days later, we're going to sleep back in the ER with the readmissions. In general, our readmission rate was 7%. Readmission rate is variable in literature, but if we go to Talim, who studied a very large group of patients, a 30-day unplanned ED utilization was 11% in the study, with a readmission rate within 30 days was 5.3%. So it was still over him. Majority of our readmission was female, of course, compared to the males. And we noticed that the readmission is within the higher group of BMI, between the 40 and 60. As noted by Guy, who noted that the readmission is associated with an increased BMI. We noted that older patients have found lower readmission rate, probably because we're taking more care of the older patients, because either for their age or associated comorbidity. Therefore, we suggested that we will change our protocol to pay more attention to the younger population and provide a more closer postoperative follow-up. This finding may contradict what Berger et al. Found in his analysis of the data registry, who concluded that the BMI and the length of stay were not associated with the readmission, like in our cases. For the readmission, we have 42 cases were readmitted. 8 of them required surgery, 2 of them required endoscopic intervention. And here we come to the golden question. So, does the hospital accreditation affect the rate of ED visit and the readmission? In literature, there is a lot of controversy. Some support the idea, and many no, saying the accreditation doesn't overall change the readmissions or change the morbidity or doesn't affect the performance. In our scenario, it does affect the rate of hospital utilization, the rate of ED utilization. For the Center of Excellence was 39%, it dropped to 32%, and the rate of readmission was 10%, it dropped to 6%. So yes. So in conclusion, the most common reason for bariatric surgery patients to visit the ER were abdominal pain, hydration, nausea, and these complications likely to attribute to the poor patient compliance with diet, stating the importance of having a good educational program. Having a dedicated accreditation program helps in reducing the ER visit and the readmission rate. However, there are other suggestions to reduce the ER visits, implementation of the telecommunications, ER system, and MDT approach was recently introduced in our team by Mehdi. All this will affect the ER visits on the long run, hopefully. In our study, we have limitations. We cannot access the patients outside the ministry facilities, that's in the private sector. And still we need further analysis, especially for to study those patients who have comorbidities. Does it really affect the rate of ER admission or not? And thank you at the end.
So thank you.
Open for questions.
Yeah, thank you very much.
I can't hear you.
Do you hear me?
That means
do you hear me?
You can hear me, right?
I listen to you. Do you hear me?
Okay.
Okay. So, do you hear me? Yes?
Yeah, I can hear you now, yeah.
Okay, thank you. So, thank you, Dr. Maki, for the nice presentation. I ask to the participant if there are questions for Dr. Maki. No. Okay. So, yeah, I have a question. I have seen your slide, and you had, unfortunately, as everybody, I suppose, the decreased number of the surgery due to the pandemic period. And did you establish some new algorithm or some precautions and preventions, not only for the patient, but also for the surgeon in OR when you restarted?
When we're going to start, this is not in our hand. This is up to the ministry guidelines. We're going to start probably after 2 weeks. They promise us at the end of June, we can open back elective surgeries. Our head of department put some algorithm for the accumulated cases. Regarding the ER utilization, we made a meeting with the ER, what to do with the cases that come back to the ER. We're following the ACES protocol algorithm for the cases that comes back to the ER, what to do, when to do, and what to proceed for.
Okay, so you didn't start yet?
No, not yet.
Wow, wow.
Yes, because our hospital is the main hospital in Sharjah. It is the tertiary center of bariatric, but at the same time have the highest ICU volume in probably in Sharjah or half of UAE. We have 6 ICUs, 2 critical cares. I don't know how many isolation units. So yes, those evacuated, we cannot start.
Wow.
Yes.
Wow. Terrible. Wow. I didn't know. Sorry. Okay. I didn't know. So, yeah, I understand. So I thank you. Thank you for your participation.
Thanks for the kind invitation.
I really wish you the best for the restart. And I wish you can really start in the next weeks, as you mentioned.
Hopefully.
And maybe you can work more than usual in order to reproduce the same numbers.
Inshallah.
So, thank you.
Thank you.
Now, now it is a great pleasure to to call to the speech Professor Miroslav Ilic, and he's very known, a full professor in the Department of Surgery in Serbia, Faculty of Medicine, Novi Sad University, of Novi Sad Atuk Velikova, if I pronounce well. So, Professor Ilic, it's a great pleasure to see you and to have you as a speaker. Thank you.
Thank you very much. Thank you very much. I would like to thank to all of you, my dear colleagues. Of course, Ezisurg as a company, I do a lot of with a lot of products of Ezisurg, and I do bariatric surgery, let's say 14 years, and most of my patients, most of my operations are a sleeve resection, laparoscopic gastric sleeve resection. So, but I also do another procedure as a mini gastric bypass, bipartition, Roux-en-Y, and revisional surgery. So I don't know where is my lecture. I ask people from Ezisurg to put me my lecture. Let's say share. Share screen. Can I get my presentation here? Right. Sorry, you cannot see my presentation?
No, we can see your face. You have to, listen, you have down into the Zoom, you have a share.
Is it okay?
Yeah, now it's perfect. Yes.
Now it's perfect. Good. I would like to talk today about how to do a proper laparoscopic gastric sleeve. And of course, I would like to point that in my practice, I considered laparoscopic laparoscopic gastric sleeve as a first choice in bariatric surgery. I don't know what happened now. Sorry. I don't know why. Okay. From the study of SM Boss randomized clinic trial, we know that there is no significant difference in excess body mass BMI between laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass when you look in a period of 5 years. It is a large study. Of course, a laparoscopic gastric sleeve also is good for remission of diabetes. And, you know, you can see also newest study from literature that study reports remission in gastric sleeve and Roux-en-Y, let's say, very similar. So we must talk about what is a good laparoscopic sleeve resection. This is why one of my first patients, you can see large sleeves is not good surgery. You can see fundus, which were not resected proper. So, and the beginning of this surgery, literature talk about neo-fundus or something like that. But we know today that it was a fear of going up to the hiatus and not to resect the proper fundus of gastric resection. And another question is also, let's say, preservation of antrum, yes or no, and how to do that. Also, in the beginning of this procedure, you can see one of textbooks that you can see a large antrum leave after sleeve resection. What is that? I ask question, should we improve technique of laparoscopic gastric sleeve? I think yes. When you see a mechanism of action and reduction, you can see a big antrum. Reduction in volume results in increased intraluminal pressure, and it's proved with manometric study. And most of experts today move to start resection, of course, 3 centimeters from pylorus, because they saw that a large antrum is not good for their patients. And all story about antrectomy, let's say subtotal or radical antrectomy with gastric sleeve, begin in 2014, and today, when you see newest data from literature, performing of a laparoscopic sleeve gastrectomy with a radical antrectomy could improve weight loss at 12-month follow-up, but exposed to lower food tolerance and higher transitory, I pointed out a higher transitory gastroesophageal reflux disease. Differences seems to be reduced to 24 months. I agree with that. And you know, another study from with manometry told us that preservation of antrum in gastric sleeve does not change in gastric emptying. So when we resect antrum, we have good gastric emptying, or let's say fast gastric emptying. So there is no reason to not resect antrum in laparoscopic sleeve gastrectomy. Of course, we know that obesity is chronic disease, and in my opinion, one bariatric procedure cannot solve a lifelong fight with obesity. And of course, for our surgeons, we must talk about first option and second option, and later on what will happen with our patients. This is my patient, and in recent years, I do laparoscopic sleeve, as I can show you on these pictures. You can see pylorus region, which is very good mobilized. Of course, some adhesions, good mobilization of fundus. And then I put a probe, which is 12 millimeters, through the pylorus, and you can see through the pylorus. And then starting with first fire, I always started with gold first, and then I use blue cartridges, Ezisurg, and resection of fundus. You can see very, very near, maybe 1 or 1.5 centimeter from, you can see, I always do with 3 ports, all my operation, and then resect a little bit of fat pad, and this is after resection. Of course, when you are aggressive to the antrum, you can see some serosal tears after firing staple gun. So always, or let's say in always 70% cases, I use reinforcements with suture V-lock usually. And this is a picture how sleeve after resection. Of course, we always make a probe with methylene blue. 30 or 40 millimeters is quite enough to fill up all. This is resected specimens. You can see J shape. You can see antral and fundus resection, and of course drainage. And so when you see data from literature, sleeve gastrectomy has significantly lower risk of reintervention in all categories. But of course, after sleeve gastrectomy, there is a numerous malabsorptive operations and numerous of possibility what to do if patient reweight or have some another problems. You can see this. I think all surgeons must be very close with all these interventions. And in conclusion, I think I do 1,000 laparoscopic gastric sleeve resection during these 14 years in 3 centers in the Balkans, in Novi Sad, is my town, and in Belgrade, which is capital of Serbia, and in Montenegro, in Podgorica, which is capital of Montenegro. There is no chance that my patients go on some other side, and I think with this laparoscopic gastric sleeve procedure results are very good, and I'm in practically a lifelong contact with my patients, and for 24 hours in my practice. So I think laparoscopic gastric sleeve resection is a good operation in metabolic surgery, and we must always try to improve good operations and not to go in some unexperienced adventures in surgery. Thank you very much.
Oh, thank you very much, Professor. Very nice talk. And also the picture of the OR, it was quite well, and reproducing what you said. My first question is, do you have experience on sleeve gastrectomy with preservation of the antrum, or you only do like you mentioned?
In the beginning, I follow you know, results from another centers and people. So I always try to resect antrum much more as I can. And in the meeting in I think Madrid, I met Professor Michel Gagné, and I told him that there is one video of him where he left a lot of antrum, and have a little bit discussion with him, and he told me now he performed anthrectomy, of course, and after that, few months after that, there was a published book, Perfect Gastric Sleeve Resection. He was a main author, but also in that book there is no clear point what to do and how to do anthrectomy or radical anthrectomy with sleeve gastrectomy. In the recent years, the last 4 or 5 years, I perform laparoscopic gastric sleeve resection with 3 ports with radical anthrectomy.
Yeah. Okay. Yeah. And okay, because my only point is I don't have experience on a sleeve with anthrectomy. I used to stay in our group. We used to stay roughly 5 centimeters far from the pylorus, and but I mean it's there is of course a different philosophy and different trends. You cited you have more than 1,000 patients treated with this technique. I don't know if you have already published some early results, but if not, or long term, also if the follow-up, as in the main study, is not 100%, I wish you, suggest you to publish, because it's a very huge experience and can contribute to the scientific audience to have an idea on this technique added to the antrum, because not most of the surgeons perform it. And maybe you can focus also on the side effects like gastroesophageal reflux, as I mentioned, if you can report. And so technically, when you start the sleeve, I have seen you use gold. You use only gold, or you switch sometimes to thicker, like I showed, for example, green or black?
Yes, you're right. You know, I operated a lot of patients with after balloon, and they have an enlarged and very thin wall. So sometimes I made the first staple in that case is with thin wall of gaster. I put blue, but sometimes, of course, there is a, when you feel that antrum is thick, I use green. I use green. Also. And not always. And in my hands, last when you put last staple gun on the very near hiatal, I use always blue, white vascular cartridge.
White.
White.
For the last one.
Yes, last one always white, because you know, I think that most important thing in fistula, after that, 2 reasons are for fistula, high fistula. One is you left a large antrum, and with very strong backup forces to the up to the ventricle, and the another possibility is weak when you have a swallow of saliva or First, that is very dangerous. Is weak on the last staple gun. So I need thin, and I feel comfortable with this.
Very interesting. Very interesting, these technical points, because I think you are one of the surgeons using white load in the last stapler, in the last firing, because this is the region, like you mentioned, of the fistula. And usually the surgeon used to prefer other thicker stapler. Huh? And it's a very important what you mentioned.
Can I something suggest to you?
Yeah.
I have, of course, some cases with fistula, and comparing antral and middle ventricle, I have more fistula in antral and middle part of ventricle than high. I have and I started after last my high. I have 2 high fistula. I started with white. That's why I started with, let's say, thinner loading of cartridge.
And very nice replay. And you have the problem of the fistula in front of incisura angularis. This is the point where you have.
Yes.
Usually, and going back in the surgery, in the cases you had the fistula, you used gold, you used green, or you switch from one color to another one, or you use the same color? No,
I switch from green to yellow or gold, and I switch gold in blue, and I switch the up blue in white.
So you use 4 colors.
First, yeah, I use first yellow, 4 or 5 blue, and last white. I use 3 colors.
Yeah, but probably, yeah, but I don't know, but probably the blue used in the body and antrum must be probably I don't know. When I don't have this experience about leak in the antrum, but when you say me I had more leaks, it's because probably you switch from a thicker to a thinner stapler, and the tissue remain quite thick. So I don't know, maybe. But in any case, you know, I use because we are speaking about sleeve. You presented the sleeve, so we speak about sleeve. And in case of sleeve, maybe I maybe try like a suggestion when instead to switch from yellow or gold to blue, to do the third free stapler in green, and then when you have bypassed the body and the antrum, and you reach the pouch if you want, like in bypass, you switch to blue. Maybe in this way you can reduce your incidence of leak. I don't know, maybe.
You know, most important problem after sleeve in my hands is bleeding from the resectional line. That's why I saw my colleagues, they oversew staple line. In my hands, I put a probe, I put a bougie, and there is no place to make a serosal inversion of staple line. I never do over switching and body, and sometimes in antrum, yes. So I don't use reinforcement serosal stitches, and I'm very careful to stop bleeding from the resectional line. I always cauterizing recta branches from the body and in the gaston. Do you understand me?
Oh, absolutely, Professor. I understand very well. And what I propose you maybe is instead to consider the suture open sewing, you can, when you have a green, for example, and you have a bleeding, because this is your proposition is, if I use green, I have a problem of bleeding. Yes, you can occur a problem of bleeding, but not always. And sometimes when you have a bleeding, in any case, you can treat this bleeding with just the hook, with just some spot of hook in 50 coagulation, no more, just a little bit in order to avoid a necrosis of the tissue, just to stop the bleeding and to avoid the suture. So maybe.
That's it. I always do that with a 20, you know, calculation 20, no more. And I'm very, very careful to do hemostasis.
Yeah. Anyway, okay. So there are questions from other surgeons for Professor Illich? No. Your talk was very clear. So we are at 1 minute to 11, and I call to the webinar the team from Ezisurg Medical in order to, first of all, thank again this opportunity to stay together these 2 years, to share experience, to learn from each other, and also to know the stapler you offer to the surgeon and the different loads and the application in bariatric surgery. It was a very nice time to meet all of you. I thank you very much. We surely have the possibility to do other webinars until when the pandemic situation will finish, and to meet personally, like in the back in congresses, and discussing the stand of Ezisurg about the different aspects we spoke together this morning virtually. And so I really thank you. I hope to meet you again online in the next months, and I wish you all the best for your surgery and your patients. Thank you very much.